eCQM validation plot, excuse me. My name is Mike Saperstein, Marketing Manager with the Spectrumetics team. Before we begin, I'd like to just go over a few quick housekeeping items. At the end of the webinar, there will be a brief Q&A session. Feel free to enter your questions during the webinar at any time in the webinar control panel, and then we can address your questions at that time. Additionally, there'll be a short break during the presentation for a poll question. We would love it if you would take the time to answer it, as it helps us to refine our webinars and provide even more meaningful content in the future. After the webinar, we'll be sending each attendee a follow-up containing highlights from the presentation. First, I'd like to introduce today's panelists. The first will be Dr. Raj Lakhanpal. He is the founder and chief executive officer of Spectrumetics, as well as a member of the HIMSS Clinical and Business Intelligence Committee. Previously, he founded Health A to Z, an online wellness and population health management platform that assisted health plans and other clients to reduce their healthcare costs. Dr. Lakhanpal is currently on the Board of Trustees of the University of the Sciences in Philadelphia and is a fellow of the American College of Emergency Physicians and the Royal College of Physicians and Surgeons in the United Kingdom. We'll also have Mark Bryant, who is the Director of Sales for Spectrumetics. He is currently responsible for new business development and client relations. Previously, he held senior account executive roles with both Sun Microsystems and Iron Mountain. Next, I'll briefly go through the agenda. First, we'll focus on understanding the CMS eCQM validation pilot. Next, we'll go through the findings and address the key issues found within, including accurate and automated data mapping, alignment of clinical workflows with eCQM specifications, as well as QRDA generation and electronic submission. Finally, we'll have a look at the Spectrumetics eCQM reporting solution and how it can help you meet all your reporting needs. So without further ado, I'd like to turn this over to Dr. Lakhanpal to begin the presentation.
Thanks, Mike. Good afternoon, everyone. It's a pleasure to present to you. I'm Raj, and as Mike had mentioned before, please enter your questions and we'd be very happy to answer them afterwards. Joining me is also our product manager for eMeasures. Joining Mark and I is our product manager for eMeasures, Kumar Kandaswamy, who is, who can answer all your questions about EC. So what has changed for 2016? What's very important is that now you don't need to submit, separate measures for HIQR, which stands for Hospital Inpatient Quality Reporting, for Meaningful Use or the Joint Commission. You can select four eCQMs that are mandatory for IQR or HIQR, Hospital Inpatient Quality Reporting, and you can submit all the four eCQMs will qualify for all three programs, IQR, MU, and TJC. And you only have to report for one quarter, Q3 or Q4. So by not reporting for IQR, as you know, is mandatory for this year, for 2015 reporting in 2016. And if you don't report, it's a complicated formula, 1 quarter reduction of the hospital market basket. It translates to about 1.25% to 1.4% of your Medicare reimbursement. So it's significant for you to report on. And all three of them, the deadline for that is 2/28/20. Must begin to plan now, or must start, if you've not planned yet, must move quickly on that. If you're also reporting PQRS through eCQMs, you need to report on 9 measures across 3 domains. But you'll have to report for the whole year. Now, as PQRS is not, PQRS and MIPS is not a subject that we're going to talk a lot about today, but the multiple reporting options for PQRS. One is through eCQMs, the other is through qualified registry, of which we also are. Spectrumetics is also a qualified registry. You can report that as well. And all of this needs to be reported in a QRDA1 format, but please, you must begin to plan for eCQM data capture and reporting now. Next slide. Now, I think you're all aware of what eCQMs are. Instead of clinical quality measures, eCQMs are e-clinical quality measures. So, and the biggest difference is that you capture data at the point of care. So as you're doing things in the hospital, you are capturing electronically, you're capturing data. So the few advantages of that, the biggest one is that you're reducing the manual chart abstraction, and which is it's a significant cost savings. But also, and you're obviously satisfying regulatory reporting, especially HIQR, MU, and Joint Commission. But also, very importantly, since you're capturing data at the point of care, you're preparing for continuous quality improvement or continuous performance improvement by seeing how you're performing at the point of care. And to keep in mind also that all hospitals and ambulatory providers must use an ONC 2014 certified technology for the 2015 eCQM version. That's the standard terminology to be used. So biggest difference is data you're capturing is at the point of care for continuous performance improvement, as well as reducing your cost of manual chart abstraction. So CMS did a pilot in 2015, the summer, spring of 2015, 29 hospitals were involved. And really the biggest goal of the pilot, there were some goals of the pilot. It was to assess the accuracy and completeness of eCQM data, evaluate the hospital and CMS's readiness to submit and receive eCQM, readiness to support eCQM reporting and data validation, and then identify the need to implement updates to measure specs as needed, subsequent measure specs, and then plan future additional validation requirements. Next slide, please. So this is what they found. They found that the guidance by EHR vendors to the hospitals was, and this is going back a year and a quarter, so at that time they found that the guidance was not enough for full automation of the process. Because a number of workflows had been customized by hospitals or health systems, most mapping by the hospitals had to be done manually, completed manually, and a significant number of data elements could not be extracted to create QRDA1 files. If I remember correctly, only 15 to 20% could be done completely. The rest had to be extracted manually. And some of the big findings were some of the key findings are also that hospitals had modified their workflows so they did not align to eCQM specifications. Elements were documented in more than one location during the normal clinical workflow. For example, in a patient transfer process, it was recorded, the patient transfer was recorded when an order was generated, when the order was placed, when the order was signed, when the patient left the facility, and when the patient was placed in a bed. So the hospitals needed more, and EMR vendors needed more guidance to determine which event best described or best corresponded to the intent of the measure. Another example was, and we're finding that as we're going through our eCQM projects, that the discharge status location is incorporated, in the discharge. The location is incorporated in the discharge status, which should be two discrete fields. The discharge status should be one, location should be another, and so I think more needs to be done to assist hospitals in improving how they capture ECQM. So coming off that, I'm going to take a few minutes to talk about how do you prepare for 2016 requirements. And the 4 areas I'm going to cover are understanding eCQM data requirements at a very high level, capturing data and remediating gaps, eCQM calculation and improvement, and electronically reporting eCQM. And let me take the example of stroke 2. That's a measure, and the measure is ischemic stroke patients prescribed antithrombotic therapy at hospital discharge. So I think with the example, these things will come alive. So in this case, it's stroke 2 measure, ischemic stroke patients prescribed antithrombotic therapy at hospital discharge. So the denominator in this case will be all patients with a principal diagnosis of ischemic stroke upon discharge. So that's the denominator. The numerator in this case will be all patients with a diagnosis of principal diagnosis of ischemic stroke upon discharge that were prescribed antithrombotic therapy prior to discharge or upon discharge. And the exclusions in this case would be patients that passed away or patients that were transferred. So patients that expired or were transferred would be exclusions. They're not added to the measure calculations. Now, just complicating it a little further, there are exceptions, and the exceptions in this case would be patients that refuse medications, patients are allergic to medications. The exceptions are new to eCQMs. They were not there with manually abstracted measures, but exclusions were there. So next slide, please. So same example, denominator is, we talked about the denominator to capture who received antithrombotic therapy prior to discharge or at hospital discharge. In the eCQM cases, we follow a QDM, which is called a quality data model. So quality data model, quality data attributes, quality data types. So it's a very standard way of capturing data. And we use standard value sets and code sets. And the code sets we use in this case, because it's about medication therapy, antithrombotic therapy, is RX norm. And then even within RX norm, we capture standard ways of capturing dosage, frequency, refills, route of administration. So all that is captured in a standard format so that we can then create a QRDA1. A QRDA1 can be generated. And so as I mentioned, standard formats, it could be structured data as well. It's the same thing. It's captured as a structured data format to be captured. And then, you know, as I mentioned earlier, a number of clinical workflows in the past, hospitals had, or health systems had modified their workflows to suit how they do work. But now, because we have to capture data in a standard format, the workflows may need to be adjusted so that, you know, a QRDA1 can be generated. Now, it's very, very important right at this point in time, or, you know, for you to start and say we have to identify data gaps that are there so that we can capture data in a standard format. And again, Spectrometics can help you with that. Keep in mind, eCQM specifications change every year as new additional data elements will be required to capture the eCQMs. So using inability, or if you have significant data gaps or you have data gaps, that will obviously lead to incorrect results. And this is a slide that talks about different eCQMs. So on the ones that are highlighted in green or that have green around them are eCQMs. HIQR is hospital and patient quality reporting, MU, TJC, those are the 4 eCQMs you need to report on this year. On the ambulatory side, MU, meaningful use, EP is eligible professional eCQMs, and then if you're a health system, that's reporting for PQRS. And PQRS is, by the way, mandatory this year, and from next year, it's a component of MIPS. So the quality reporting is a component of MIPS with significant amounts of incentives or penalties in place. So if you please also think of reporting for PQRS. So those both can be reported as eCQMs as well. So reporting for eCQMs need to have, they have to be done in a QRDA1 format. And the QRDA1 format contains the patient's quality data along with demographic information, race, age, gender, sex for that reporting period. And then it's submitted for each patient that meets the initial patient population criteria for one or more eCQMs. This is a good slide. I like it because as CMS is trying to align all the programs together with the Joint Commission, and there's a lot of talk about CMS and NCQA also aligning the measures together. So you can capture data once and report for many quality programs, many pay-for-performance programs, many value-based care programs. And so one is obviously the standard HL7 QRDA1 file format. As Spectromedics, we also provide a data specification file format where you can, at your institution, map the data elements so that to generate QRDA or for us to then process quality measure reporting. Or if you do not have that capability, we could build an agent for you, an eCQM integration agent that could collect the data automatically to generate the eCQMs. So the center of the shows how data then goes into the eMeasure framework and how we generate a QRDA. But very importantly here, you can generate data once or collect data once, capture data once for HIQR, for meaningful use, for the Joint Commission reporting, as well as PQRS eCQM reporting. And then also, if you are using HEDIS measures for certain pay-for-performance programs, that could also be done so that all the now reporting programs will become aligned or are becoming aligned. Obviously, HIQR, MU, and TJC are aligned, and the other ones will be becoming aligned as well.
Thank you, Dr. Lakhanpal. Now we're going to take a short break and present a survey question. The question is, what do you see as your biggest challenge with eCQM reporting? The 4 choices are extracting data from multiple sources, aligning clinical workflows to satisfy eCQM data requirements, identifying appropriate eCQMs to calculate, generating QRDA1 files that satisfy CMS submission, or choosing an eCQM reporting partner. The poll is now open. We'll give everybody a few minutes to answer, and I'll be back with the results. Thank you, everybody. It looks like aligning clinical workflows to satisfy eCQM data requirements is our biggest pain point. Now I'd like to introduce Mark Bryant to continue the presentation.
Good afternoon, everyone. Thank you very much again for joining us today. We really appreciate this opportunity. So for the next slides that I'm going to be speaking to is telling you a little bit about us, walking through our solution, and then talking about our engagement process. So at SpectrumEdX, we help hospitals and health systems transition from fee-for-service to fee-for-value and other risk-based models. We can do that in 3 ways. Number 1, the ability to consolidate data across disparate systems, and I'll talk specifically to how we can support you in capturing the right data for eCQM reporting. Number 2, providing a measure framework to calculate both hospital and ambulatory programs. And again, today's focus will be on eCQMs for hospital and patient quality reporting, meaningful use in the Joint Commission, but we can help expand to other programs. And also analytics, supporting both inpatient analytics for predictive modeling for readmissions, value-based purchasing, HAI, and also a lot around today around population health analytics, risk stratification, geo-mapping and hotspotting, creating dynamic disease registries for our clients. Below, I have some select clients and partners. We're happy to provide you a full client list if you wish, but just to highlight a couple for you today. First, we're very proud of our relationship with Haney Solutions. Haney's is a division of the Hospital Association in New York. They've endorsed our PQRS solution for their members. We're doing significant work around Medicaid reform with Medicaid analytics for New York State DSRIP. We're highlighting here both Mount Sinai and Staten Island, which are 2 regions underneath the New York State DSRIP program. For the Mount Sinai program, we're supporting them with measures for their PPS so they can track their projects and maximize their incentives. We're also working with them on their clinically integrated network of 3,400 providers who need PQRS and HEDIS measures to track and to report. For the Staten Island Perform Your Provider System, we're providing them a complete IT platform for data aggregation between their hospitals, and underneath New York State DSRIP, you have to work with your ambulatory practices as well, so consolidating data from behavioral health, long-term care, primary providers, providing measures, a framework again to maximize their incentives, and also population health analytics so they can understand their attributed lives in their community and engage with those members. Richmond University Medical Center, we're providing hospital analytics for them. We're also, we've supported Greater Hudson Valley Health System and Auburn Community Hospital for PQRS reporting. And finally, Quantros. Quantros is a key partner of ours, and if you're a Quantros hospital on this call, we appreciate that, and please, if you have questions, engage with them or engage with us. We can coordinate it. But we're supplying, an eCQM platform for their member hospitals as well. And we can also, we're integrating with Oracle. So if you have an Oracle platform, we can integrate off of that. So the first stage is understanding your data sources. And I'm going to speak in the next couple slides specifically to eCQM and how we can capture data for eCQMs. But as a whole, we work with our clients to understand, what are they looking to report on, what type of analytics are they looking to utilize, and we can integrate, extract data, integrate data from survey data, from any of the EMRs. We can pull in lab data. We can, if you have a health information exchange, we can integrate with the HIE. We can pull in billing and claims data. We extract that data, populate an enterprise data warehouse, and then layer our measure framework around that. So on the hospital side, we're certified for all 29 hospital electronic clinical quality measures to support HIQR, meaningful use, the Joint Commission. We can also build measures around HAC, HAI, value-based purchasing, and any other custom initiatives. On the ambulatory side, we can support all 64 eCQMs for PQRS and for meaningful use. We're also a qualified registry and have 169 PQRS measures we can support if you wish to report via registry. On HEDIS, NCQA actually approached us last summer. They approached us and selected us to be part of a pilot program to help them develop electronic measures, HEDIS measures. We successfully completed that with NCQA, and we're being certified now for STAR and hybrid measures. And we can support other value-based care and risk-based models, any other programs that you might be involved in, whether that's Disrupt in New York State or other states, whether you have an accountable care organization, patient-centered medical home measures, and any other custom initiatives as well. This next slide is just a summary of what I just spoke about. I'm just going to point out two pieces to this. We have a full line of predefined measures, and as measures change or new measures are published, we update our measure specs automatically for our clients. And the way we do this is, and what we feel is a significant advantage for us, is that we have a measure authoring framework that sits behind our tool that allows us to rapidly define measures, the variables that are needed, the calculations, and the rules that pertain to each measure, so we can properly understand the data elements that are needed and to calculate that measure and successfully report on it. We can then help to create custom programs for our clients, whether that's for commercial payer reporting, whether you're involved in a Disrupt program around the country, other Medicaid reform programs. If you have a clinically integrated network, if you have an ACO, we can help you create those measures, create those programs, be able to report on them, and give you a platform for tracking those on an ongoing basis. And I'll show you a glimpse of our portal in an upcoming slide. So the first stage specifically for electronic clinical quality measures is to understand how we can extract data. And I'm going to go through in the next slides structured formats. But if we need to extract data directly from your EHR, we'll map out and understand which measures that you're looking to report on out of the 29 eCQMs. We'll understand which elements we need to capture, and we'll extract those elements from your EHR system. And it could be EDT encounters, pharmacy data, lab data, data from your ED. We can also marry in other billing data as well if need be, but radiology data. So we extract that, we consolidate it, we map it to the elements needed to report for each of the measures, and then we standardize it. And that could, for an example, if there's duplications of a patient record, we'll deduplicate that record. And we do this ongoing. So every time we take in a batch of data, when we set up a batch process with you, it could be biweekly, monthly, quarterly. Every time we bring in that data, we run it back through our measure framework, and we go through the consolidation, demapping, and the standardization process. And Raj had stated and showed this slide earlier, and it's a great slide because you can capture the importance of capturing data once and being able to leverage that to report to many. And so number one, we can support taking in structured data formats such as a QRDA, a CCDA file. In the case of PQRS, we can bring in 837P for the billing data. If you cannot produce those files, we can work with you to understand what measures you're looking to report across multiple programs, provide the data elements needed in a structured format to you, and help your team run the query to provide that data to us, to push that data in a different format to us. And then third, we can build a custom interface into EHRs, and we're doing that with multiple EHRs today, including Epic, Meditech, eClinicalWorks, Cerner, and such. So once we have the data, once we understand the best way to access your data, and it could be a combination of those formats, we then populate our enterprise data warehouse, layer our measure framework around it to be able to calculate the measures, give you dashboards to track it, and I'm going to show you that next. And then we handle all the submission process. So we generate the QRDA that needs to be submitted off for HIQR, meaningful use, PQRS, for the Joint Commission, and NCQA and such. So our portal is role-based, and this is completely customizable for each of our partners, our customers. So we see it as there's 4 main roles that we offer. The first is an executive role. The executive could be a CMO, Chief Quality Officer, Director of Quality and Performance, CNO. that's looking at a whole, at your enterprise or your health system as a whole, and wants to drill down, wants to track multiple programs, be able to drill down into those programs to see summary. So how you're comparing as a health system, for instance, for HIQR, how your individual hospital is performing on HIQR, and then going down into the measures themselves to do further comparisons. Attached to that executive role is an analyst role, an informaticist role. That position is going to look at what programs that you're looking to track, go into the individual measures, and then be able to drill down into the patient-level details to really do the true performance improvement, to understand where there's gaps in the data, where there's workflows that might have been missed that can be remediated. So on an ongoing basis, you can improve upon these measures, and that's crucial. And as Roger said, it's crucial to get started now so you have time to improve upon these measures prior to submitting in February of 2017 to get ahead of it, look at your measures, improve them, and such. Attached to the role is a submitter role. It could be a separate role, or you could give the analyst that permission as well. And this person is going to go in the case for HIQR, is going to go in prior to the deadline at the end of February, look across the measures that you're tracking. If there's 4 that are mandatory, but we may be able to work with you to identify other measures, additional measures to track. So then you can look and select the measures that are performing the best. Select those measures. That then generates a report to us that we formulate and send off to CMS. That role can also access that final report at any time for compliance. And then finally, we also offer a provider role, and this is really key on the ambulatory programs like PQRS, where a provider can go in and look at their patients as an aggregate and drill down to view gaps in care, utilization, demographic information, have a dynamic disease registry of their patients so they can on an ongoing basis look at who their patients are and improve care for those patients. So for purposes of this webinar, we know that we don't have a ton of time, so we just wanted to give you a couple of snapshots of our portal. We're happy to do a much larger demonstration one-on-one if you wish. But for the executive role, looking specifically at hospital inpatient quality reporting, again, an executive logs in, sees their health system as a whole, drills down into a hospital, and looks at the measures that that hospital is tracking. And in this case, we've picked out 3 measures. There's benchmarking attached to those measures, so we'll customize that with you. You can choose the benchmarking. It could be a national, state average. It could be an internal target. We give you 2 benchmarks to utilize. And then it's color-coded. So if you're meeting or outperforming both benchmarks, it's in green. If you're underperforming one of the benchmarks, it's in orange. And if you're underperforming both, it would be in red. So this allows that executive to see from a quick glance how you're performing, can then drill down, and if it's a hospital program like HIQR, can see comparisons between hospitals if you have multiple hospitals under your health system. Ambulatory can see provider comparisons, and it gives that overall opportunity to improve. And in the analyst role is going to look at the specific measures that are tied to each program, in this case HIQR, be able to see who made up the initial patient population, who qualified for the denominator, any exclusions and exceptions that Raj spoke about, what those mean, and then who qualifies ultimately for the numerator, and that affects your performance. And from here, be able to see the patient-level details. So this is important so they can actually roll up their sleeves and do the true performance improvement. They can look at each patient. If they were included, great. If they were excluded, why? If we look at patient F. Brown, they were excluded because there's data missing. So here's an opportunity to go back into your EHR and make sure that data is mapped correctly so that we can capture it and we can calculate that measure. There could be a clinical workflow issue or change that needs to be made. And then once that data is completed, if you've added that data into the EHR, the next time we capture your data, we extract your data, we'll run it against these measures, and that patient then would hopefully be qualified for the numerator. And then again, through the analyst role, it could be a separate role. There's a submitter app portal, and the submitter will be able to choose those measures that we would then submit off to CMS in the Joint Commission. And so how do you engage with us? What does our process look like? So we see there's 4 areas for our process. and I'll go into them a little bit more in a second. But first, there's an assessment that we offer. Then there's a remediation period that kind of extends over with the implementation and training period, and that's all done prior to going live. And then we offer ongoing managed services through this. And we see this process is generally taking, anywhere from 2 to 4 months, depending on how fast we can get the data and the quality of the data, and making sure we can calculate the measures that you need. And the way we kick this off is through our assessment process. We feel is a great value add. We'll work with you to first understand your readiness. What data can you give us? What measures are you looking to track? We'll get a sample amount of data. We'll run it against the electronic clinical quality measures, all 29, and for the case of HIQR, the 28 measures. And we'll provide you a report back up front before we get to implementation, before we go live, that shows, A, can you meet at least 4 measures right now? And then B, are there any gaps in the data? Is there any remediation that you can start to do so you can start to do the performance improvement now? And we know there's a lot of angst in moving to eCQMs from the manual abstraction. This will give you the comfort to know that you can report, and if you can't, how can you get up there quickly? How can you improve these measures so you can be able to satisfy this and you're not at the gun at the end of the year trying to submit for that. And then once we do go live, we'll provide ongoing managed services, so we'll maintain the portal. We'll work with you and understand how often you wish us to capture the data and extract it and calculate the measures. You'll have the portal to go on for performance improvement. We'll handle all of the submission to CMS and to the Joint Commission for eCQMs. As new measures, measures are changed each year or new measures are added, we'll handle the specification updates, and then we'll let you know if any of those changes affect the data elements that are needed to calculate the measures, and we'll work with you to address those gaps if there becomes a gap in data. And we do this, throughout our relationship. And to summarize on why we feel that we can offer, a great value to you as a partner, whether you've gotten started already in eCQMs or you haven't gotten started yet, is number one, our readiness assessment can give you that comfort, can give you that knowledge up front before going to implementation on where you stand with electronic clinical quality measures, what you can report on, what you can calculate and report. We can help you just develop a strategy to improve your workflows. We can help you track and improve the performance of the eCQMs through our portal. We'll generate all the QRDA1 file that's needed to satisfy both CMS and the Joint Commission. And we'll help you. We'll be your long-term partner to comply with other programs. This is just a start. As you take on new initiatives, as you expand, whether it's for more eCQM reporting, whether it's going from PQRS to the merit-based incentive payment system, for ACO programs, we can give you that one platform to track all measures and support you through that journey. So with that, I greatly appreciate your time. We're going to now turn it back over to Mike for our question and answer session. We'll be joined by Kumar, our product manager, for this as well. But I greatly appreciate your interest and your time today. If you have any questions, please reach out. We welcome the opportunity to have a more in-depth conversation with you and see how we can add value. So with that, I'll turn it over to Mike. Thank you.
Thank you very much, Mark. It looks like we had a bunch of excellent questions come in during the presentation. Let's start with number one. We understand that you're only reporting 1 quarter for eCQMs. Do you know if we need to report for the reporting year for other requirements? Turn this over to Kumar.
Yeah, hi. I'm Kumar Kandaswamy. I'm the product manager. So the eCQM reporting data for eCQMs are 1 quarter. It's a mandatory requirement if you are doing an electronic submission for meaningful use and HIQR. But if you are reporting through attestation, as you know, meaningful use can be satisfied through attestation as well. So if you're reporting with completing the web forms, you have to report the entire year, and that's for 2016 you have to report the entire year. Now, for other components of meaningful use, you need to work with your meaningful use certified vendor to make sure you satisfy those requirements.
Thank you, Kumar. Next question. For HIQR eCQMs, can a chart reviewer abstractor take non-structured data and enter it into the structured data element, such as EKG interpretation written on the EKG by the MD, and the abstractor enters the interpretation in the structured data field?
Now, as part of the requirement to calculate or to capture data for eCQMs, calculate eCQMs for eCQMs, the data has to be captured at the source. What that means is, either a nurse practitioner or a physician, captures those data using the EHR. So, abstracting data after the fact is not how you would go about capturing data for eCQMs. That's one of the reasons why we recommend all hospitals to start the process early, soon enough, so you can identify which 4 measures you can really report based on the data that you have, and focus on those 4 measures for this year.
Thank you, Kumar. Next question. Could critical access hospitals be selected for eCQM validation?
So the eCQM, so critical access hospitals are not required to report eCQMs this year. Although they can report, it's not mandatory to report eCQMs. And the validation project, we would say recommend contacting CMS for participating in any project for eCQM validation. But again, critical access hospitals are not required, even though they are are recommended to report eCQMs.
Okay, the next question I think we'll have Dr. Lockenpaul take. Can this platform apply to the ambulatory environment for reporting of physician PQRS outpatient measures?
Yeah, sure. Yeah, so it's as Mark had mentioned, we have a measure authoring tool that enables both us to calculate and report on both the hospital side and the ambulatory side. So short answer is yes. It can enable both EPMU eCQMs as well as PQRS eCQMs.
Next question. Do you work with Meditech?
Sorry. Yes, we do work with Meditech. We do have Meditech clients where we pull data from the Meditech DR data repository and calculate eCQMs for those clients.
Okay, let me add to that. So the 3 ways, like any EMR vendor, we could, if you are a Meditech hospital, you want to generate a QRDA1 and give it to us. For us to calculate, we can do that. We can give you a data spec file, and you can, leverage your own IT team and give the data to us to calculate eCQMs. Or third is we can work with you where you say, look, where we don't have the IT resources to do that, so we could build an agent that could automatically extract data to calculate eCQM.
And the final question is, could you please clarify the difference between exclusions and exceptions?
Sure. So on the eCQM, the exclusions and exceptions are defined at the measure level. So you need to understand, based on the measure, what exclusion criteria or exception criteria are used. On a high level, exclusions are those patients who are, excluded from the denominator before they qualify in the numerator. Some of the reasons could be patient expired, patient got transferred to another facility, whereas exceptions, on the other hand, are cases where patient refused medication or there was a medical reason for not providing a a medication for the patient.
Okay, guys, thank you very much for taking the time to attend. Once again, if you have any other questions or would like to set up a demo, please feel free to contact Mark Bryant using the information on this final slide, and we hope you have a great day. Thank you.